Good afternoon, everyone. The talk I'll be giving right now is quite interesting place. It borrows a lot from the talk that we had right before lunch. Borrows a lot or comments some on Professor Joey's talk as well. So it's almost as though this was perfectly planned. They line up very well. My name is Dr. Gilbert Mbeo. I'm also from this lakeside community. I was born and raised in Nairobi, but actually went to school not too far from over here, St. Mary's Yala. So about maybe 40 minutes matatu ride down the road. And Kisumu is home, so this is quite good. I went to medical school at the University of Nairobi, and at some point fell in love with neurology. And actually quite privileged to be in the presence of two people that really inspired me to go down that path, Professor Joey and Dr. Oluwato. Quite privileged to be speaking on the same podium as the people that made me who I am. After medical school in the University of Nairobi, I traveled over to the United States, trained in general neurology, and then subsequently trained in neurocritical care. And I'll use this talk maybe to talk a little bit about the concept of the neurocritical care unit and the concept of the benefit of having such a setup in the setting of traumatic brain injury and neurology and neurosurgery in general. So this is your typical neurocritical care unit. So it's an ICU that is specialized in taking care of patients with traumatic brain injury, talk about subarachnoid hemorrhage, intracranial hemorrhage, talk about neurological conditions that need really close monitoring. So we're saying status epilepticus, neuromuscular respiratory failure. So a complex, highly monitored setting, an ICU that's usually carved out. Now the concept of the ICU is not new at all, and in fact Florence Nightingale realized that in patients during the war, during war, patients that were taken care of in a monitored setting with hygiene being a big issue had much less mortality, and that was the birth of the critical care unit. The occurrence of polio is now what really cemented that in medicine. The neurocritical care as a standalone unit is a fairly new concept, and so what we've started to realize is that patients with neurological neurosurgical needs, complex neurological neurosurgical needs, end up actually doing better. They have much better outcomes when they're taken care of in a setting such as a neurocritical care unit. Now, this unit is probably familiar to Dr. Naote. This is the Emory University Neuro ICU. So we crossed paths at that point. Came as a neurosurgery resident, actually leaving, and myself as at the time an aspiring neurology resident, and subsequently a neurocritical care fellow. Now, walking into a neuro ICU in the ideal setting, this is what you do. This is the kind of patients. These are the machines we were talking about in use. We've got complex monitoring going on. We've got the EEG running. We've got several monitors talk about the base monitor, ICP monitor running. We've got cardiac monitoring, looking at hemodynamics and things of that nature. Some patients who we've decided to institute aggressive modalities for, say, managing temperature. We have a cooling catheter placed or surface cooling in place. So a really complex patient, and I remember when I was a medical student at University of Nairobi, we called that the ideal setting. My vision, my dream was always to see that ideal setting one day show up in Kenya, and I believe we will. This is the first step. Now, this is the typical rounds in the neurocritical care unit, very multidisciplinary, as Professor Joey was actually talking about. So, multidisciplinary, we've got clinical pharmacists during rounds, we've got our clinical fellow during rounds, we've got our nurse practitioner, our physician assistant, we've got neurosurgery residents, we've got anesthesia residents, sometimes emergency medicine residents, we've got neurology residents, we've got nutritionists, caseworker. So a lot of the people that come into place to give the patient question the best outcome. Usually educational, so educational rounds, and as we exchange ideas, what you'll see is presentation by whomever is tasked with managing the patient, and then a very educational discussion, because again, we're talking about really complex patients with complex needs. Now, learning objectives of this lecture. So this lecture actually borrows from a series of lectures from the Neurocritical Care Society. So as a specialty, neurocritical care is fairly new. we've come together as a society. We call that the Neurocritical Care Society. Majority of neurointensivists are neurologists by training, so neurologists that did further training in neurocritical care, usually a 2-year fellowship. Some neurointensivists are internal medicine trained, and then we'll go into neurocritical care. Some neurosurgeons find it interesting, and then they'll take a 1-year fellowship and get into that. And we're all organized under that society. We have guidelines, what we call the EMLS guidelines. So think about it like ACLS, and so the resuscitation guidelines in patients with cardiovascular compromise. We have a very similar set of parameters that we teach. So very easy to transfer those skills so that waking up at 2 a.m. and I know the algorithm will follow for our neuro patients. So this borrows a lot from ENLS. Now, today we will talk about how to diagnose and classify the severity of TBI. A lot of that has been talked about already. Talk about the rationale for preventing and managing secondary injury. We've talked about that as well, but we'll add on to what we've already spoken about. And we'll talk about some of the steps in the EMLS algorithm. You may be familiar with this already, and Dr. Gala did a great job listing out the evidence for the different things that we do for our neurocritical care injured patients, our traumatic brain injured patients. And we look at care for these patients as falling in the different categories. The pre-hospital stage, the emergency department stage, and then at that point we're going to be beginning to consider medical versus surgical interventions, and then we'll go deeper into that. Epidemiology, we've also talked about that. Now, a comment over here, there is a paucity of data in our setting, and very ideal, I think, is going to be the day when we have our own data and we can talk about the incidence of TBI in Sub-Saharan Africa and actually in Kenya and be very accurate about it, and what happens to your patients with TBI. But in the US, about 2.5 million patients per year, about 283,000 end up hospitalized, and 52,000 will die from that. I think that was one of the questions that came up a little earlier. Leading cause of death and disability in young individuals, and by far the largest reason is falls and motor vehicle accidents. In our setting, for sure, motor vehicle accidents, and add on the border that we're all familiar with. Pathophysiology also been talked about in the previous lectures, so I'm not spending too much time over here, but maybe one thing to comment on is again the concept of primary brain injury and secondary injury. So primary being what the initial insult that will occur, and the secondary injury phase, one of the phases that we're actually very, very concerned about, and we try to take advantage of care to give the patient the best outcome. Now, we want to focus our care on preventing secondary injury because these are injuries that are major determinant for how the patient will do. They can be controlled, and this injury happens at the microscopic and the macroscopic level. We're talking about excitotoxic cascades that begin to trigger cell death. So some of this is an important phase where we can intervene and make a difference. Now, the causes for secondary brain injury, blood pressure, a big one, so hypotension, and the recommendation usually is avoid hypotension, because with hypotension in a patient that has already had compromised intracranial hemodynamics, hypotension will not be good. So avoid hypotension, and that actually has been shown to have an impact on mobility and mortality. Avoid hypoxemia. Again, a chance to improve mobility and mortality. So we've got certain numbers we target for our partial pressure of oxygen when we're taking care of such patients. Avoid metabolic disturbances. Some of the things that we mean over there is genes of sodium, hypoglycemia, hyperglycemia, things of that nature. ICP management, which we talk about and has been talked about, accommodation seizure management. So some things that we can intervene on to help reduce secondary injury. Initially, evaluating a patient with traumatic brain injury, what was the mechanism of the injury? In our setting, many times will be automobile accidents, as we talked about, and motorcycles, construction injuries, as we've already seen, and many trauma, assault, things of that nature. Things to look at: what is the patient's exam, what is their GCS, a very easy way of communicating across providers, across consultants about the state of the patient. And again, it gives us an indicator for how severe. So a GCS of less than 8, we think about that as a severe TBI. 12, moderate, 13 to 15 mild. The neuro exam. We many times will forget the neuro exam. So we forget the neuro exam, not realizing that a lot can be used with that examination. So what is the neuro exam at that presentation? Consider other causes aside from TBI. You found the patient unconscious. What else could be the cause? Could this be hypoglycemia? Could it be hyperglycemia that you can fix? Things of that nature. So consider other causes for loss of consciousness. Not spending too much time commenting on the GCS, aside from the fact that it was actually taught to me by Dr. Roger Luna, and that was actually the lecture that inspired myself to become a neurologist. So the GCS, you can take a look at it, quite familiar with it, and important to communicate across all of our providers. Now, in the pre-hospital phase, spinal precautions. So a patient with brain injury possibly also has spine injury, stabilize the spine, and until we can clear the spine, rule out any spine and spinal cord injury. Basic airway management. So airway management. What's happening? Are they protecting the airway? And some of the things that you may hear us talk about in the neurointensive care setting is what we call rapid sequence intubation. So rapid sequence intubation. So patients that need to be intubated to prevent respiratory compromise. Normal breathing, so there's a concept of hyperventilation transiently to help with increased ICP. Prolonged hyperventilation not good because it can cause more harm than good. What is the glycemic level? Are they hypo or hyper? Assess the GCS as we talked about, and again some of the basics in ACLS and BLS. Expedited transport, quite important. I guess some of the things that we need to really see if we can change in this setting, because this is the low-hanging fruit. Our emergency services, what can we do? What can we improve? I think as a county, hopefully one day in Zoom we can see a very robust emergency service system. Blood pressure treatment, we talked about some of the parameters that we look at. Hypertension is bad. I will leave it at that point. So hypertension is bad. We will not aggressively elevate by giving pressors, but hypertension is bad. So treat it as best one can. And these are the parameters. You'll be able to read that in spare time. Avoid hypotonic resuscitation. So hypotonic fluids for resuscitation. So you'll see us reach out for normal saline. Now there's half normal saline. There's dextrose 50, so D50. There's D5W. So we avoid the hypotonic solutions in favor of our solutions that are more physiologic. So normal saline is what you see us reach out for, sometimes plasmamide and then sometimes adaptive adrenals. But hypotonic solutions not good. In the first hour, what should you have accomplished? Secure the airway. Ensure that your blood pressure is well monitored and well controlled. Avoid hypotension. C-spine precautions. Brain injury can occur, many times does occur in the setting of spine and spinal cord injury. Imaging, as soon as we can get our imaging, so obtain NCT, treat or diagnose and treat herniation. And we shouldn't forget the neurological exam. So we tend to rely so much on imaging and things of that nature, but what is the neurological exam? So that's a good checklist to go by. Now, in the ED, so patient presents after being mobilized and brought in from the community. Secure the airway if we need to. And again, we commented on the concept of rapid sequence intubation. Avoid hypotension. Treat hypotension. Our same oxygenation parameters as we have talked about. Our same spinal precautions as we have talked about. Access that one would need. So some form of vascular access. The most experience to obtain would be a regular IV, so a large bore IV. Sometimes in that setting we will take advantage of that initial setting to place a large central venous catheter, so subclavian lines or femoral lines, so some large access. If all those not possible, an intraosseous, but some access. Keep on following the GCS, and a very easy way to communicate amongst consultants and amongst collaborators the status of the patient. Monitor for hypoglycemia and treat hypoglycemia. Hypoglycemia will worsen this onset of neurological injury. Address some of the life-threatening non-TBI injuries. We'll have a brief slide on coagulopathy in the setting of TBI and obtain your imaging. Now, on the imaging, we usually look at serial imaging. So serial imaging. So your initial scan, you look at me as we see right over here. And these are some of the patterns of injury that we've already talked about in previous lectures. So our epidural hematoma, our contusions, our diffuse axonal injury, which is quite interesting because as unimpressive as it seems, it's not unusual to find a patient with small particular images who looks more moribund than a patient with massive image. So look out for that, and just be aware that that is a signal to bad neuronal damage. Subdural hematoma, subarachnoid hematoma in the setting of a trauma, and then just diffuse cerebral edema. Now, we talked about serial imaging. So imaging on the what may look as we see, not unusual in the first 24 hours to see a deterioration, so a blossoming of the hemorrhage. So you'll see in for the initial say 1 or 2 days serial imaging just to see the progression of this hemorrhage, being aware that these hemorrhages do blossom. Now, once we're in the emergency transitioning to the intensive care unit, again, some of the things that we've talked about: avoid hypotension. Hypotension is going to worsen any neurological injury. Maintain adequate oxygenation if we need to. If the patient has not been intubated, make sure that again we discuss the patient adequately, avoiding hypotonic solutions. Now, the concept of managing increased intracranial pressure. So we're familiar with the Neurocritical doctrine. So the fact that our brain is tightly packed within the skull. Within that compartment, there are 3 things that contribute to our intracranial pressure. Majority being the brain, parenchyma itself, blood, and our CSF. Now, all these are existing in a state of equilibrium. When you have an alteration in one of these components, the other 2 need to be adjusted accordingly for you to maintain ICP. And that's this section of our curve, the lower section of our curve, where that compensation still exists. At some point, that compensation is overcome, and that's when ICP begins to elevate. Now, why and when will you start to treat elevated ICP? So, as you're following your exam, what are the pupils looking like? So, do we have an anisocoria, unilateral dilated pupil? Do you have dilated non-reactive pupils? Do you have, as we talked about, asymmetric pupil? What does the mode exam look like? Are we seeing any posturing or lack of response on one side? Are we seeing a decline? So, a patient that came in, came in intact with a decreasing GCS. Are we getting clues that the ICP is getting elevated? So talk about Cushing's response, the Cushing's triad, where you may start to see different smatterings of hypertension, bradycardia, and bradypnea or irregular respiration. Some of the criteria that you will see followed for placing ICP monitoring, GCS being a big part of that consideration. You've seen an image similar to this in the past, and then this is just commenting on the different monitors that we have available. Gold standard being the intraventricular drainage device, and that's because it gives us a chance to monitor ICP, but also to divert CSF and help to some extent with increasing ICP. We've got epidural monitors, we've got brain tissue intraparenchymal monitors. So we've got different ways that we're able to monitor that, the gold standard being an EVD. How do we medically treat elevated ICP? So my comment to residents as we're formulating our plan for managing our patient with ICP, very initial, intubate, transiently hyperventilate, intubate, hyperventilate, intubate, hyperventilate, transiently. Prolonged hyperventilation will actually cause the opposite of what you're trying to achieve. Mannitol, depending on the access, so mannitol, so 0.5 to 1 gram per kilogram of mannitol. I tell my residents or my fellows, wake up at 2 a.m., increase ICP, give 100 grams of mannitol. So 0.5 to 1 gram per kilogram of mannitol. Once you have central access, different concentrations of hypertonic saline, 7.5% and 23% hypertonic saline. And we talked about hyperventilation with a target, and that's usually short term. The concept of multimodality monitoring. So, in the pre-launch talk, we talked about the Raleigh Chestnut study. So a study that actually really shed light on, is there a benefit to multimodality monitoring? And the end result of that study was a really good exam would be just as good. And these invasive monitors that we have available will not necessarily improve outcome in patients. It gives us a target. So sometimes you see us resort to using multimodality monitoring in our patients in certain settings. Different monitors that we have available, ICP monitors that we talked about, sometimes transcranial Dopplers, so do that serially, and there are devices that can do that almost on a continuous basis, but not clinically available, more on the research side. Brain partial pressure of oxygen, so oxygen probes sitting within the brain and giving us an idea of what the brain oxygenation is like, so we can avoid hypoxia. Cerebral microdialysis, so again, we have that sitting inside the parenchyma of the brain, giving us an idea about what's happening in the milieu of the brain. So what's our lactate to fibrate ratio, things of that nature. There's EEG and there's continuous quantitative EEG, so different very interesting EEG parameters we can look at. And as Prof. Joy mentioned in his talk, so the incidence of seizures post TBI, fairly common, and not all that shakes is a seizure, and not all seizures will shake. So you may have a patient just lying there having seizures, what we call non-convulsive seizures. So sometimes a way of monitoring for that might be beneficial. A patient we've seen before, so at the beginning of the slide, so again, bringing us back to what your typical patient in the neuro ICU with really complex needs would look like. Indication for surgery, nothing to really stress over here, but has been talked about in the slide before. And comment on coagulopathy in the setting of TBI, fairly common, and so aggressively doing the best one can to reverse any coagulopathy, because coagulopathy in the setting of TBI with hemorrhage will result in worsening of the hemorrhage. Seizure prevention, we've talked about that in the previous lecture. Typically in the neuro ICU, you may see some patients, not all patients, some patients started on an anticonvulsant regimen for 7 days. If they have no evidence of seizure activity, we will discontinue that. If they have seizure activity during their stay in the neuro ICU, we'll send them out on anticonvulsants, and that will usually be taken off by the neurologist on the outpatient side. And this will be something interesting to pull up, literature on seizure prophylaxis, so the benefit and the agents to choose. So look at management of TBI almost the way we look at management of sepsis, so what we call goal-directed therapy. So in the critical care literature, we talk about goal-directed therapy in sepsis, and we are formulating the same concept in managing our TBI patients. So goal-directed therapy, what are your goals? Maintain adequate oxygenation. Maintain certain CO2 parameters for certain durations, maintain certain physiologic parameters at certain levels, as you see over here, maintain temperature. So hyperthermia is bad, so hyperthermia we aggressively treat fever, because fever is bad and cause worsening of that onset of a neurological injury. Look at anything that relates to coagulopathy, aggressively correct that. Blood pressure goes as we talked about, ICP goes as we talked about, cerebral perfusion pressure goes as we talked about, and goals related to glycemic control. Analgesia, sedation, commented on also in the talk before lunch, and some of the agents we end up were resorting to in the ICU, setting, the neuro ICU. And when we call a neurosurgeon, so again, this is directed mainly towards the initial person receiving a patient with TBI, and some of the things that should clue them in to call in the neurosurgeon. So GCS, any seizures, lateralizing findings on the exam, abnormal CT scan, CSF leaks, so autouria or rhinorrhea, penetrating injury, CT findings not matching the clinical findings. So remember we talked about the diffuse axonal injury, which sometimes will be misleading. So a little speck of few specks of hemorrhage in a comatose patient, something may be going on. Planned cerebrovascular injury. We'll talk about this in subsequent slides, and C-spine injury. Things to communicate. Again, this is not necessarily for the neurosurgeons in the room, but for the initial patient, the initial individual taking care of or receiving the TBI patient. What is the age? What is the mechanism of the injury? What comorbidities exist? What medications are they on? What are the imaging findings? How do they look on GCS after any initial resuscitation has been done? What interventions have been done? What focal findings are there? What is the coagulation status? They may need to go to the OR what other injuries exist. Is the cervical spine stable? Is it not stable? Is it clear? Is it not clear? What are the vital signs? And in some patients with TBI, we also look out for vascular injury. So aside from injury to the brain, that initial injury to the brain, there's a high incidence of vascular injury in certain patients. And some of the clues, and this is in the setting where people use a lot of seatbelts. So the seatbelt abrasion sign. So clues that you may be dealing with an injury so severe that we injured the carotid. So the vertebral artery, vulnerable in some patients with brain and spine injury, and things to look out for: thrombosis, vertebral thrombosis. So thrombosis resulting in infants higher up in the vertebral artery territory. Carotid dissection, as we alluded to a couple of slides before. So dissection of the carotid, and such a patient with the initial injury then manifesting with a large ischemic stroke. A few considerations for TBI in the pediatric population. Leading cause of injury and leading cause of death in the pediatric population. Falls are very common. Motor vehicle accidents, bicycle accidents, and sports injuries in older children. And again, these statistics more in the West. We need to really develop our own internal numbers. Considering that setting also low abusive head trauma and GCS is useful even in patients, in young patients, as long as they're about 3 years old, and studies have shown that. And that is the end.
Thank you. Do you have any questions?
That was an excellent talk, and my question is, in this resource-limited environment, could you tell us what your goals are, what you're up to, maybe what your current progress is, and what the future might bring? Because again, it would be nice to have a state-of-the-art neuro ICU bed now, and maybe there will be one in a couple of years. But if you could give us an update, I'd like to focus on.
Great question. And I guess my comment on that is, as I mentioned earlier, during training at the University of Nairobi, I remember a common comment during rounds was, the consultant would ask, what should we do? And many times the answer would be, in the ideal setting, this is what we will do. In the ideal setting, but yes, we'll watch. But in the ideal setting, this is what we do. The long-term vision for this is to actually have that ideal setting closer to home. And then it may not be, all facilities being the ideal setting. Let us have one, maybe two of that ideal setting, facilities that give access to a lot of our population. So a few years from now, we should have that ideal setting in neurological, neurosurgical, neurocritical care. Where have we reached? What progress have we made? I think just the fact that we're sitting in this room as we are is evidence for that progress. So all this began with a foregoal and a vision from individuals with that common desire to effect this change and create this ideal setting. So we made some progress. Now, as far as the local situation, I think we're still in most facilities outside of Aga Khan, for example, Aga Khan Nairobi, in fact. Outside of that, I would not be surprised if making rounds, the statement began in the ideal setting, and we need to change that. We need data. We need our own data. We really need to do carry out studies. I put that out to anyone out there who is interested in a collaboration with gathering data. What is the TBI data that we have over here locally? So that's somewhat frustrating, but I think the signs that we're headed towards better times.
Hello, my name is Kola. Thank you for your presentation. My question is, in a setup where our patients present as long as 15 hours post-traumatic event, 20 hours later, how beneficial is initiation of mannitol at the time of presentation? The number two question is, how soon do we initiate anticoagulant therapy for patients with intracranial hemorrhage once they present?
Very good questions. So mannitol is not only useful as an initial medication. So a lot of what you do will be dependent on the exam. So if there are any signs of elevated ICP, we talked about anisocoria, we talked about a worsening headache, we talked about focal neurological deficits and things of that nature. And imaging also showing signs of increased ICP, so brain swelling, brain herniation, and things like that. Mannitol is still useful. We use mannitol for several days in the post-TBI period. Now, we use mannitol bearing in mind that too much mannitol can actually have an effect on the kidneys, so it can be, it can be nephrotoxic. And so we really try to shift from mannitol in the initial phase, eventually to hypertonic saline. So initially, you see us try to get very good vascular access. Our central lines, our subclavian lines, or femoral lines. If that's not able to, we can get that, and you see us use hypertonic saline. But mannitol useful even beyond that very initial period. So a lot depends on the exam. Your other question was related to coagulopathy or initiating your thromboprophylaxis, your DVT prophylaxis. Question that may have been dealt with in the pre-lunch talk. Guidelines we usually follow so two things: stable imaging, stable exam, regardless of time. Stable imaging, stable exam. So if you have stable imaging where you're not seeing blossoming of the hemorrhage in serial scans, a stable exam where you're not seeing a patient that's decompensating right in front of you. So if you have stable imaging, stable exam, 24 to 48 hours, and many people will find that middle ground, which will be 48 hours. But regardless of that 48 hours, you must have stable imaging, stable exam. You don't want to start in a patient that has a blossoming hemorrhage.
Thank you. Our next speaker, thank you so much.